I'm gonna cover that too.
Oh.
And then I also use
Oh, the graduation. Oh, yeah. That's
Alright, good morning everyone. How is everyone? Woo woo! Okay, your blueprint will be posted today for your exam. Okay? The blueprint for your exam will be posted today after lecture. So you'll have that, okay? Because I know you're all very, very worried, but you don't have to be. You're all gonna do great, okay? That being said, I wanted to go over this question in particular from your quiz last week. So while working in the pediatric clinic, the nurse receives a telephone call from a parent of a 13-year-old who is receiving chemotherapy for leukemia. The patient's sibling has chickenpox, or varicella. Which action are you going to take next? 5 of you said that you wanted to prepare to admit the patient to a private room in the hospital. What was your thinking behind that?
Mostly to isolate them from the sibling.
Yeah.
Okay.
that.
But-
And also, if they've already been exposed, like my thinking was if they've already been exposed, then they might start showing symptoms.
They could, they're not yet. So there's nothing in this specifically that would warrant an admission to the hospital, right? Like if you took your kid to the ER and just said like, hey, sibling has chickenpox, admit me to the hospital. There's no real admission criteria that they've met in order to be
I guess
admitted,
I
right?
was thinking, since they have the cancer, they're already established, obviously they're doing stuff there, but.
Yes, absolutely. But when you're looking at like the bigger picture of like just this here, or like, I guess not bigger picture, smaller picture of just this in general, right? There's nothing in here that had like, they haven't met any admission criteria because they're not sick or anything. It's just saying that the sibling has chickenpox, right? So there's really nothing that would warrant them to be admitted to the hospital. 14 of you said you wanted to educate the parent about contact and airborne precautions. What was your thinking behind that?
I thought because the mom was at home, so I thought that you would educate them before they come to the hospital. You know what I mean? Like you'll educate them before they come to the hospital about what was going to be happening.
Okay. So your thought process was we're gonna do this because they're going to come to the hospital and this is what we're gonna do, right? But that patient isn't the one with chickenpox, right? It's the sibling again. So education, yes, is important, right? That it is an airborne and contact spreading disease process, right? They can kind of do that at home, but not the airborne, right? Because normally we would put them like in a negative pressure room, right? And they can't really do that at home. So I see what you were thinking. Who else wants to add in what they were thinking to that one?
Leukemia has like immunosuppressed, right? So there's other contact that 13-year-old or that patient.
Yes. So the correct answer was to administer that varicella zoster immune globulin, IVIG, right? Do you remember talking about that
Mhm.
in class? Yeah.
When I looked at it, the reason why I didn't pick IVIG is I was like, that's a really extreme measure
Yeah.
for something that you don't know is confirmed or not.
For them though, it's not that extreme because they can't get the vaccine because they are immunocompromised, right? Because varicella and your MMR are live vaccines. So depending on when they were diagnosed with this, they might not have even gotten their vaccine, right?
Because I was thinking that too, like, we don't even know what
Yeah.
they have.
Because there's nothing in here that says anything about their vaccine status, right? So we're not sure if they're vaccinated or not. But knowing that the varicella vaccine is a live vaccine, our chemotherapy patient can't get it. However, they should have gotten it when?
1 and 4 years?
Yeah.
1 and 4 years, right? So the first one at 12 months or a year, and then the second one between like 5 and 6, or 4 and 6, right? So ideally, they actually should have already had that, and they would be protected. But if they didn't, you're IVIG, because if they're immunocompromised, their body isn't going to be able to produce an immune response to that infectious process. So we're gonna essentially give it to them, right? IVIG is essentially a bag of immune response cells, right, to fight off that infection. Okay, so because none of you got it right, you all got the point, right?
I think my point is infection, because I took it separate.
Yes. Send me a message. I'll take a look at yours. Yeah.
So they can get that IVIG anytime being immunocompromised.
Especially if they've been introduced to something like some like highly infectious process, we'll give them IVIG to boost up their immune system, right? Especially during a time when they don't have an immune system. Because while they're actually getting chemo, we're wiping out their immune system, right? But in between their immune system does come back, and they do have somewhat of a little bit of a protection, right? But during chemo, it wipes it out.
For me, kind of threw me off that it was like a phone call, because I was like, how am I gonna like, I don't know.
Yes, yeah.
Yeah.
So you would have them come in. You would have them come into the clinic instead of being admitted to the hospital, and then you would administer that.
I think
Yeah.
I saw it, I didn't take in immune globulin, and I thought like, yeah, the vaccine, and I'm like, they're not able to have like that right at
Right.
that time. So
Yeah.
I think that's fair.
Yep. And Michelle and I talked about it, and we're gonna rework this question.
Yeah, my kind of thought process is, just because this one is sick, this one is immunocompromised, if they're not close together, or if they stay separated for the time being while this one, the disease runs its course.
But who's going in between them? Their parents, right? And so even though they're not necessarily gonna get sick, they could potentially still carry that, like especially like if they were touching something that the infected kid had, or just like being near them, right? They could carry that over. And we see that a lot with like the upper respiratory infections.
But at the same time, if you're educating parents about contact and airborne precautions, if they're maintaining PPE and whatever, then they wouldn't be passing it on.
Yeah, but airborne precautions, can't that even go through the vents and stuff, like they can't do that at home?
Yeah, they can't do that. They can't do airborne at home, right?
Mm-hmm.
And then contact, like, it's. Do all of the nurses in the hospital wear their PPE correctly?
No.
Right? So that was a big thing. That was a big issue that I had during COVID. So we saw our pediatric patient like completely, essentially, fall off. Right? We had like no patients. So we were being used elsewhere in the hospital until the other departments were like, well, why do the Peds nurses get to cover the front door? Why can't we? We're not getting any hours. And so then they were like, then they decided that they were going to send us to the COVID floors, and like for the onc nurses, we would go up there, and then if one of our patients was admitted, they would pull us back from the COVID unit to take care of our oncology patient. And I was like, this is not okay. And they're like, well, everyone should be wearing their PPE. You're wearing your PPE. I'm like, yeah, I am, but I can't guarantee that everyone else is. And if I don't have it on and I'm just out at the nurse's station and everyone else is out there too, and they weren't wearing it appropriately, they're going to infect everything. And then you want me to come back and take care of an oncology patient? Absolutely not, right? And so you're just like looking at all of those pieces, right? So we talked about it and we decided like we essentially nullified this question. Everyone got the point, and we'll rework this question for the future. Okay. Cool. There is one more that I wanted to go There's two more I wanted to go over. Okay. So the first one here, frequent developmental assessments are important for which reason? So only 9 of you got it, but 3 of you responded critical periods of development occur throughout childhood, which is the correct answer. The other 7 of you said stable developmental periods during infancy provide an opportunity to identify any delays or deficits. So do our frequent developmental assessments just stop in infancy? No, they continue on, right? All of those well child visits are our frequent opportunities for assessment, to determine where they're at developmentally, right? Because they could get through early childhood and then all of a sudden they have an issue, right? And now they're not where they should be and they're falling behind. So those frequent developmental assessments are critical periods of development throughout childhood, right? Not just infancy, which is why this one was incorrect. Okay, cool. And then, what? This is the next one. So, which expected outcome is developmentally appropriate for a hospitalized 4-year-old? So the correct answer is that they will independently ask for materials to play or personal needs, right? They should be voicing, I want to go to the bathroom, or can I have something to play with, or something like that. That's what that's asking about, right? For the first one there, the first option, the child will be able to verbalize an understanding for the reason of the hospitalization. Should a 4-year-old be able to tell you, I am here because my appendix burst and now I have an abscess and I'm getting IVs and stuff like that, right? That is way above their understanding. The child will have a parent stay in the room at all times. Remember what I said about parents and staying? We encourage it, but it's not required, right? So this is essentially saying that it is required that a parent stay in the room at all times.
But
right?
is it developmentally appropriate for them to stay?
So it,
They're gonna freak out.
but if they're not there, right? So the piece of it being in there at all time, because the parents don't have to be there all the time, right? And sometimes they can't be there all the time. So this one is essentially leading to that, like, we encourage it, but it's not required, okay? And then the last one, the child will be dressed and fed by the parents. Who should actually be dressing and feeding them?
They should be able to dress and feed themselves.
They should be able to do that themselves, right? So we encourage that autonomy. If they can do those things, we want them to be able to do that for themselves. Okay, cool. This one was the other one, so you should have seen that you got 2 points back because the percentage of correct didn't hit the threshold. So your grade should have, if you got it right, you didn't see an adjustment. If you didn't get it right, you got the point back for it. Okay. So overall, you guys did really well on the quiz. It was just those two that were kind of off a little bit. Okay. All right, so there was a pinning question. Right,
Okay. What?
your pinning question, what was it?
Oh, yes. For the survey, I don't know if someone already mentioned it, but it only lets you upload one picture. So I don't know if you want to upload more than one, you have to do more than one survey.
Oh, really?
I was gonna ask you, is there, who's in charge of grabbing the photos from that Dropbox?
So, as the committee, you should pick two of you to kind of manage those.
Okay.
So I can,
But if I
it's
created a
my
shared folder.
folder.
with all of us,
You could create a shared folder
so
and
that
then set it
everyone
out.
can just send in
Yeah.
all of their photos?
Yep.
Okay.
Or we can keep it in that folder and then I can just share it with you guys and then like you have editing access to that folder.
Okay.
And then you can send that link out.
Okay.
However you want to do it, just let me know.
Okay.
Put it in that group chat
Okay.
that I created and then we can go from there. Okay. So that survey, if you haven't done it, make sure that it is done by Friday, right? Who, does anyone else have questions about the pinning? About pinning, like the ceremony itself?
I have a kind of silly question. The pin itself, could my 5-year-old do it?
Yeah.
Like,
So what you're gonna get is a ribbon, and it's
Okay.
already gonna be pinned on the bottom. So you're gonna
Oh, okay.
pin the two ends together so that it just slides over.
oh, okay.
Yeah, you're not actually gonna like pin.
They're not like,
No, you'll just have to like get down enough so that they can
Okay.
like slide it over your head. Yeah. And so the ribbon and the pin, Gabe will set that up. It's after the final, so usually like the next day. So the final's on Monday, so I think on Tuesday, you'll be able to pick up your pin and your ribbon. Okay.
Grades will be open for the final.
Grades will be out Monday afternoon. Yep. So you will know. You all just like completely lost your breath. You're like, the final.
Oh, okay.
Yeah, your final grades will be, so you guys take your final that Monday, right? December 15th, whatever that Monday is. Grades will be out that afternoon. Okay, they will be posted that afternoon, so you will know. So then on Tuesday, you'll be able to get your pin and your ribbon and everything like that, as well as your tickets. So the number of tickets, I still have to get with Gabe, but he is, depending on who's coming and who needs what number of tickets, there's usually tickets left over. So it is, the number of tickets per student is totally dependent on how many are coming, and then if they're not using them all, you can donate them into the pot, and then those get evenly distributed to those who want or are requesting extra.
How many tickets do we get and how do we buy tickets?
So that's what I was just talking about. So it's completely dependent on how many students are coming, first of all, because it's in the bull pit, so we can only have a certain number of people come. And so I want to say it's somewhere between like 7 and 10 tickets, but not all students come to the pinning every single time, and not everyone needs that many tickets. So if they're not using them all, then they get kind of donated back into a generalized pot, and they get evenly distributed amongst everyone else who is requesting extra tickets. Okay. Yeah, go ahead.
So this isn't about Penny, I was just wondering, do we know approximately how long we have to wait before we can set the NCLEX?
The NCLEX site says somewhere, the AZBN says anywhere between like 6 and 8 weeks. However, last fall, most of them had already tested by like mid-February.
Okay, so.
Yeah. So the sooner you have like everything in and good to go, it's kind of on their end as far as like processing. So the process for us is that we have final grades done on Monday, and then Dr. Powers submits everything to the Board of Nursing Tuesday morning. So she sends over that yes, you have all completed your required education, you have met the requirements, everything's in, everything's good, and then then it's on the board. So however long it takes for them to process and get everything situated and get your authorization to test out to you. Once you have that authorization to test, you go onto like the Pearson website, and they have all of the available testing dates, and you can test anywhere.
Okay.
Yeah. Like I drove 4.5 hours to test. Because I wanted to do it ASAP. Yeah, so I wanted to do it ASAP. So I graduated, so I went to nursing school in Colorado. I went to a community college as well. And we graduated December 6th, and I tested and found out I passed all before Christmas.
Nice.
Yeah, it was like a super quick process. Cool.
So it's not for the CNA thing, it was the director who pinned us, so like this one you get to choose who pins you, or?
Yep, you get to choose who pins you. So for those of you who have like little kids that want to do it, you know, I think in our pinning directions it says like one person on stage. However, if you have a family member that you want to like help guide them to you, that is okay. It's just the like the waiting area to like come up on stage. There's not a whole lot of room, so we can only have like so many people there at a time. And then as far as like setting up for the ceremony and taking down and cleaning up, the other blocks will help with that. So you guys don't have to do anything, right? The pinning committee, as far as like the food and the drinks and stuff like that, however you want to manage that. If you want to like drop it off here, the faculty can bring it over, because we'll bring all of the other things. We bring your lamps that we'll use during the ceremony and things like that. So if you want to just leave it here, we can bring it all over there. But all of the other blocks, we'll put out a request for their help, and usually we get quite a few. So they'll help with like setup and takedown, cleanup, helping like put up the decorations, organizing the food, drinks, and then they'll take tickets when everyone's coming in to like get seated and stuff like that. So you guys don't have to do anything. It's all about you that day. GCU always provides a photo booth with like the stuff that you can like take funny photos with and stuff like that. They donate that every semester. So that is already done and situated, because I heard Cheryl talking about it the other day when she was here, that was all done and taken care of. So then your pinning committee is gathering your data on what you guys want as far as like food, entertainment, if you guys want anything. If anyone knows of anyone who's willing to like DJ or in a mariachi band, whatever it might be, fill out the survey with that information, right? And they'll compile all of that. and then we'll take a look at that together and then see where we're gonna go next. One option that we do have for the music, we do have Bluetooth speakers. So if you guys just want like a playlist of music, just on the speakers, Professor Harrell has those, and that's what we did last semester. We just kind of set those up in the courtyard area, and so there's just like music while everyone's like hanging out and having fun. Cool. Any other questions about pinning? Cool. Okay. Oh, yes. Thank you. I knew there was one more thing. For clinical, day 4, you have a medication teaching presentation that you are going to present in your clinical day to your clinical group. Okay. In that, you're assigned to a group, but your group is just the age range that you are assigned to. So some of you are assigned to infant, toddler, school age, adolescent, right? Or preschool, those 5. Your teaching presentation is just directed towards that age group. It is not a group project. You are going to do it individually. It's just everyone in that group was assigned that age, right? So like if you and you and you all had infant, that is all that that means, right? You just have that, but you can each and should choose a different medication, right? So one thing that I do encourage is that if there's multiple of you in the same age group and you're in the same clinical group, just make sure that you're not doing the same medication, right? Okay. That way there's a variety, okay? But that teaching presentation, so if you have infant, your education on that medication should be directed towards who? The parents or caregivers, right? Not the child, because the child is not going to understand anything because they're an infant, right? But if you have an adolescent, who should your teaching be directed to? Mostly the adolescent, right? With maybe some towards the parents, right? So as you're presenting that, you're going to present it to your group as if you're teaching that child, right? So you can pick one person that you're gonna have as like the child and the parent. So if you're gonna do both in your presentation, that you can direct your education that way. Cool?
Where are we gonna be getting those medications? Are we gonna get a list of them?
You can pick whatever medication. Yeah, so just think about like common medications that like you would see like in the pediatric age range, right? So you got like obviously like your Tylenol and ibuprofen. You got things like Keppra, antibiotics, right? So antibiotics for like ear infections, antibiotics for like strep throat.
Is there a table where we're gonna insert it, or how are we gonna know which one's what?
You can just like talk amongst yourself in your like group homepage.
Are we already assigned?
You are already assigned your age range, yes. Yeah. But if you go to the group, there's like a group homepage, and then you can just like start a chat in there. Have you done that?
No.
Yeah. You can go in there and then you can like send a message to your group and say like, hey, I'm doing this med.
Okay.
Right?
This is being taught on our 4th clinical day.
Correct.
Okay.
Yep.
So what if all the other people in my group right here are not on the same clinical day as I am?
That's fine.
Then we could all teach the exact same thing because we're not on the same day?
Yeah. As long as you're not on the same day, don't pick the same med. Right? Or you can't pick the same med, as long as you're not on the same day. Cool?
Can you pick melatonin?
You could. You can pick like Zyrtec or Claritin. Really just think about what meds you would see like in a pediatric population.
Oxygen, got it.
It's not bad.
Done and done.
It's really not a terrible idea.
right? Like you could do Miralax for like pediatric constipation, right? You can do an antibiotic for ear infection or strep throat or something like that. You can pick like, Keppra for like seizure disorder.
Let's go.
Did you have a question?
It's not related to this, but for our interview days, are we assigned those days yet? We're just trying to plan like what day I need to.
Yes.
Our cohort was the second phase.
Yes. So, if you go to your experiential course, where you have the schedules, they should already be there.
That's what it is.
You should see the schedule for the mock interview as well as the clinical judgment sim.
Oh.
I have one more question about the medication.
Yeah.
So it be just like us writing something down and just be standing, or is it something?
It's going to be like a PowerPoint presentation because it is worth points. Yes. So just read through that assignment information, and you have everything in there. There are examples of ones that need improvement, and one that's really good. Okay. Okay. Do you see the
Yes, I do, thank you.
the mock interview? The clinical judgment sim should be on there as well. Okay. Make sure on the mock interview one that you scroll to the right, and there's another table for your pinning video time. Okay.
What does that mean?
So during the pinning ceremony, when we call your name, you're going to walk to the middle of the stage, and your person pinning you is going to meet you in the middle of the stage. But you are going to record a video, like a little 15-second blip, that, in the past, students have said, I want to thank my friends and family during this super stressful time for getting me through. Couldn't have done it without them, like making meals and watching my kids, whatever it might be, right? So you'll write a little script, and then we'll record you reading your script. So essentially, so Gabe usually does it in 127 in that corner, so it's kind of pretty secluded. Not a lot of people are walking by and distracting, right? So what he's gonna have you set up, he'll have the script up on the board, and the camera will be here, and you will be here, and you can read your script as it's recording. So you don't have to memorize your script.
And you're gonna play that at the green ceremony with these.
Yeah, so we'll call your name, and when we call your name, it'll play up on the screens in the bulkhead.
And it's your face or the script?
It's your face. So it's a video of you reading your script.
Is that mandatory or can
If you're gonna be there, it's mandatory. But the nice thing is you again don't have to memorize your script, right? It's gonna be on the board, and if you don't like it the first time, Gabe will re-record you, okay? But it usually goes pretty good.
So we don't actually have to speak because our thing sounds important.
Correct. Yeah. Yeah. So you're just gonna walk to the stage. Your pinning person's gonna meet you on the stage, and then they'll slide the pin over. You can take a couple seconds for your family to take pictures from down in front, and then you'll go back to your seat, and your family member or friend or whoever will walk off the stage.
Can it be in Spanish?
Yes, absolutely. It can be in Spanish. So if you would like to record it in Spanish, you can record it in Spanish. Yep. Is there a question over here?
So we have to, is it required to have a speech?
Yes. Yes.
We have to write our own speech.
So it's just a little 15-second blip. Literally, I'm not even kidding you. When I tell you, it is mostly I want to thank my friends and family or my spouse or whoever for getting me through this stressful time of nursing school. Couldn't have done it without them. Congratulations, class of fall 2025. Something like that, right? And so I think I think in the module for pinning, is that open yet? Do you see a module for pinning yet?
No.
Okay, so once we have that open, like we'll tell you when to like submit your script and all of that. But it'll have directions in there. It'll have examples of like previous scripts before.
And
But it
that's
literally
the
is like, it's like 15 seconds.
For the clinical judgment sim, do we just come during our time frame?
Just during your time frame. Yep. Mock interviews will be like a half-day thing.
It's like it looks like we're in.
Yeah, so you're gonna do, there's a session where you have an individual interview, one-on-one with faculty, and then there's a group one where there's a group of you with one faculty, and so, and then the video session afterwards. Yep.
And after our video, we can go home.
After your video, you can go home. Yes.
What are we wearing for the mock interview scrubs?
Please do not wear scrubs to your mock interview. Business
not
cash.
the mock interview.
Business cash.
The video for same business.
Yeah, because you're gonna be, it'll be mock interview day. So that's why we do the videos on mock interview day, because you're all dressed up, your hair is nice, right? You don't have to keep your hair up, you can do your hair nice for an interview, right? I know, there are 2 days where we have a clinical experience where you can do your hair however you would like. One of them is the mock interview day, the other day is the diversity presentation day. Because that day is the day we take the class photo, and so you can wear your hair however you would like for that day. Even though you're in uniform for the diversity day, your hair can be done however you would like. Okay?
What do you guys do with those? Because I haven't seen any recent group photos.
That is a great question.
Do we get a copy of those at least?
Yes. So they will go into like that shared photo and that group folder, and then so everyone can have access to that, and then you can grab the photos from there. We are working on getting those recent photos up on the wall because they have not been up there for quite a while. They have not been up there since like way before like
I think it's
COVID.
2000.
Like early 2000s, like it's been a while since they like have had a photo up on the wall. So we're working on
There's
that.
lots of blank space in here.
There's lots of space everywhere for them to go. We just need to have them done and printed.
I can do it. Oh,
Yeah,
you
just
can print it.
print it out and tack it up there. Yeah.
I'm like, you're kidding.
Okay. Anything else with pinning? I'm trying to think if I missed anything. Oh, your gowns. During the pinning ceremony, you can wear whatever you want under your graduation gown. It just has to be white.
Oh, we organized that?
Yes, your gown is white, and your cap and gown are white.
You guys are right?
Okay. No.
It has to be close.
It has to be close. You have to wear something under it, right? You have to wear something under it.
I am one.
For the girls sitting in the front row, just know that you are elevated above everyone else in the audience. So if you plan on wearing a dress, make sure you keep your legs closed and crossed. Because there have been times where the students forget that piece and the audience gets a little show. Please don't do that. Please don't do that. I really hate having to tell a student that they have to close their legs during the ceremony.
Wait, so our outfit
Come on, we'll
is
offer
underneath
nurses,
also
please.
needs to be
No. Your cap and gown is white, but you can wear whatever you want underneath of it, right?
Wait, we have to buy
You
it
just-
just random?
So Amazon for like $20.
My high school one was.
Yeah, just a super cheap like white cap and gown.
Why did you look so stressed when you said that?
I don't think any have been donated back yet, but you can check with Professor Harrell or Snow to see if they have any, if purchasing is an issue. But please keep that in mind after graduation. If you would like to donate them back, Snow would be very happy to take them back and have them for students for next time. For those who purchasing one might be a financial burden. Okay, just like with your scrubs. So if you're going to donate your scrubs back, you can donate your gown back. And then we have those available for students who run into issues that they can't necessarily afford those. Okay. Cool? Awesome. Anything else, logistics-wise? Think we're good? All the updates?
Ready?
Cool.
Ready to learn.
Let's do it. We're gonna learn cardiac today. What?
We have our BNF meeting today, or
What time's your BNF meeting?
1:30.
Why is it at 1:30? I told them we're lecture till 2:30.
Yeah. Oh, 3:30.
2.
Oh.
Not 2:30. 2. We might end a little bit sooner. It actually depends on how fast you get through the escape room.
Let's do this.
Okay, let's do it. All right, so as we move through, the first thing that we're going to go over is just, I'm going to kind of go over a good way for you to kind of learn about all of the disease processes as we move through from here out, okay? We're going to talk about congenital heart anomalies. Congenital meaning what?
born with.
They were born with it, and acquired
They got it
After birth.
after birth, right? So congenital, they were born with it. Acquired, it happens sometime after birth. It could be, diet related, right? So like hypertension, something like that, or heart failure as a result of a congenital defect that they have, right? So it could be that it's acquired all on its own from an infectious process like Kawasaki's or rheumatic fever, or as a result of one of the congenital defects causing like heart failure, right? We'll go over congenital heart defects case study, an escape room, and then I doubt we'll have time to get to the Caleb Yoder case study, but I will put that in there in your module as an additional resource for you to go through. It really looks at like cultural components when it comes to cardiac care or care of a kid with a cardiac disorder who's also Amish.
Oh.
Okay. So taking that cultural component in, because we know that like they've got a lot of restrictions on what they can and can't do as a cultural component, right? So again, an additional resource because I doubt we'll have time to get through it today. Okay, so the best approach for learning all of these disease processes from here, kind of moving forward, and even like the respiratory ones from last week, right? The best way to go about doing it is your concept map, right? So, your traditional concept map, you start with the disease process and then fill in all the boxes on the outside, right? But you can also reverse concept map where you have just all of that stuff on the outside and take all that data and see if you can plug in which disease process goes with all of those findings, right? So, looking at the patho and how it affects physiology, right? So with cardiac, we've got the patho of those abnormal openings in the heart. So how does that then affect physiology, right? Well, the biggest piece of that physiology is the oxygenation or perfusion, right? So if the blood isn't moving in the right direction that it should, it mixes with deoxygenated blood, which then gets sent out to the rest of the body, and they look what?
Blue.
They look blue, right? Okay. So then you're looking at what data assessment confirms this. So you're looking at vital signs, their presentation, right? We talked about your assessment starts when? When you first walk in the room, right? So do they look blue to you? Do they look lethargic? Do they, how do they look? And their relevant history, right? Whether that's just them or family history, right? Because some of these congenital defects can be family correlated, right? And we'll take a look at that when we get to our case study later. Looking at your nursing interventions, what's going to correct the patho, right? So if we have a VSD, what's going to correct that? Surgery, right? A lot of time it will actually close on its own, so sometimes it's just time, right? And maybe symptom management at first to see if it will close on its own, right? If not, then we'll have to do surgery, okay? But looking at that, like what's going to fix it? How do you know that it's working? are you getting your expected response, right? Like if you give them a medication, is their perfusion getting better, right? Do they look as blue as they were before, right? So did they improve after you did that intervention, right? Okay. What are relevant labs? For cardiac, there's really not a whole lot of relevant labs to like diagnose, right? It's more what? Signs and symptoms and imaging, really, right? We want to know what the electrical pathway is doing in the heart, so like EKG, but then we also want to do like an echo, right? We want to know what's going on in there. What are the primary medication classes that will be used to treat the client, right? So, you know, as we move through and look at all of the different disease processes that we're going to cover, obviously those medication classes are going to change based on that disease process, right? But look at it in what is relevant to that child, okay? And then with those medications, are there relevant assessments that need to be performed? So today, obviously cardiac, do you need to do relevant assessments before you give a cardiac medication?
Yeah.
Like what?
Listen to the
Yeah, you need to listen to it, right? You need to listen to the heart, auscultate that apical pulse. We're also going to feel what the peripheral pulses. Are all of the beats of the heart getting to the periphery? And do they feel equal from top to bottom and left to right? Okay. All of the pulses should feel equal. Okay. There are some disorders that we're going to take a look at that they do not. Okay. And then any side of, after you give it, are you getting your expected effect? Are you getting any side effects? Are you getting any adverse effects? Right? So we, after we do an intervention, we do what? We assess, we evaluate, right? Did our intervention work or not? Right? What patient teaching do you need to perform related to medication? So your cardiac meds. Digoxin is one that we're going to talk about today. Is there relevant education that you need to provide? Yeah. Is there relevant education you need to provide to any medication that you give your patient? Yes. You should be providing some sort of education on anything that you give, right? We kind of already touched on that one. How do you know the medication's effective? They should have improved, right? Whatever you're giving the medication for, that symptom should have improved, right? What are some possible nursing diagnoses that you can think of that are a priority in the care of a client with an alteration? Your priority nursing diagnoses are not a risk for, right? That is not a priority. It is something they have right now, right? So for our cardiac ones, a nursing diagnosis would be ineffective perfusion as evidenced by they are blue in their extremities, right? Okay, related to the fact that they've got a heart defect, okay? Your risk diagnoses are a secondary nursing diagnosis. So this would be like your bedbound kiddos who are are cerebral palsy kiddos, right? They oftentimes are completely bedbound, they're immobile, they don't get up. A lot of their movement is just kind of wiggling around in bed, and that's kind of all they have. So that would be a risk for what? Bed sores, right? So risk for skin breakdown related to immobility, right? As evidenced by the fact that they can't get out of bed, right? Okay. Make sure that you add in there age-appropriate and client family-centered teaching related to all of that. Are there any developmental concerns, right? So when we talk about like cardiac surgery and needing to keep a 2-year-old from running around all over the place, is that a developmental concern? Because that's what they want to do, right? That's who they are, that's where they're at, right? Okay. Safety concerns, environmental concerns. So are there things that families need to put in place to make sure that said kid is safe going through whatever process they're going through, right? Cool? So, concept maps make you a better critical thinker, right? It takes your linear thinking and kind of maps it out, right? So that memorization and regurgitation of information and elevating it into a creative, integrated utilization of those components to make up your required complex and anticipatory critical thinking. Cool. So it takes it from I'm going to do A, then B, then C, then D, to I'm going to look at the whole big picture, right? Instead of just going from one to the next, what am I taking in all at the same time, right? And putting it down and what's going on with your patient. Okay. You guys want a quick break before we actually get into, or you want to keep going? You good? Keep going? Okay. All right, so looking at the cardiovascular system, talking about development first. So looking at the fetal heart. Okay, so during fetal circulation, those holes in the heart are there for a reason, right? So when after delivery, when we're looking at like an ASD or a VSD or PDA, those are pieces of normal fetal circulation, right? After delivery, those should all close. But so kind of going back a little bit, the fetal heart begins beating around post-conceptual day 17, underscoring the early development of this vital organ. It develops rapidly during pregnancy, right? We've got chamber formation. There are heart chambers and arteries that form and develop during weeks 2 through 8, which is a really critical period for cardiac structural development. If something happens in utero during that time, what could happen? All kinds of things.
35 plus congenital deformities.
Right, 35 plus congenital abnormalities, right? Your book has a whole slew of disorders that could happen, right? But we know that if...
It's actually pretty incredible that that doesn't happen more often.
I know, right? Absolutely. So, you know, if in utero there was a toxin exposure or a fetal maternal illness, right? Things could happen that could cause, you know, like one chamber not to develop, right? Some kids are born with just one ventricle. Some are, you know, they have transposition of the great vessels. You know, whatever it might be. You got ASD, VSD, PDA, coarctation of the aorta, tetralogy of Fallot, right? Those are just the ones that we're going to talk about, but you have a whole bunch of other ones, right? But we know that oxygenation of the fetus occurs via the placenta, right? Bypassing the lungs, which are perfused but not functional for oxygenation and ventilation, because they're not using their lungs while they're swimming in liquid, right? It's not going to work for them, okay? The foramen valley allows blood to flow from the right to the left atrium, right? In fetal circulation, we call it the foramen valley. After delivery, we call it a what? Your ASD, right? This is your atrial septal defects, right? So in fetal circulation is a normal piece, right? We want it there. It's allowing that blood to flow from the right to left atrium, right? Because the way fetal circulation works, it's bypassing the lungs because things aren't moving through there, right? But after delivery, that should close, right? So once they start taking their first breaths, the ASD, the VSD, the PDA, all of those start to close, or they should start to close, right? If it doesn't, we end up, this foramen valley ends up being your ASD, your atrial septal defects, okay? Well, the ductus arteriosus allows blood to flow between the pulmonary artery and the aorta. That is going to be your PDA, or your patent ductus arteriosus, right? So it remains open after the time it should have closed, okay? These structures help shunt the blood away from the pulmonary circulation. Because again, in fetal circulation, they don't need it. It's not going through the lungs.
What is the difference between the ASD then and the what you just said, PDA?
The PDA. So the ASD is just in, it's in the septum between the atria, right? So there's a hole in that septal wall that's allowing for that blood to flow. Where normal circulation goes from your right atrium down to your right ventricle. I'm like, I gotta make sure it's right? So it comes in there from the body, right? And goes down to your right ventricle where it then pumps out to where? To your lungs, right? And then the lungs pump it back into the left atrium where it then goes down to your left ventricle before it goes out to the rest of the body, right? But when we have that ASD, that pressure, that pumping of the right atrium that normally would send it down into the right ventricle, pumps it to the left atrium.
Vice versa, right? Because the pressure on the left is greater, so it goes into the right side. From the left.
Yes. So it's moving it back and forth.
Yeah,
Right.
I get that, but the difference between the A and G, because they're both in the atrium, right?
Nope, so your PDA is outside of the heart.
Oh.
Yeah, so we'll get there.
Okay.
Like, I have pictures for all of it, so you'll see, yeah, we'll go through it all, okay? Yes, so your ASD and VSD are inside the heart. Your PDA, so your pedicular arteriosus, your colorectation of the aorta, those are outside. And then some of the defects with tetralogy of Fallot, actually all of those are within the heart itself as well, okay? Okay, so once they start taking their first breath, we have that lung inflation, decreasing pulmonary vascular resistance, and blood starts to flow through the pulmonary system, okay? That foraminal valley closure happens because of that increased pressure in the left atrium, and the ductus arteriosus constricts when that increased oxygen level leads to the eventual closure of that. In tetralogy of Fallot, we want it open, so we'll talk about that when we get there. But normally, it should close on its own, right? If that is the only defect they have, and it is not closing, we're going to give them some medication to close it. We'll get there when we talk about it.
For which one?
Okay, the PDA. Okay. So this transition from fetal to neonatal circulation involves significant changes in blood flow and pressure, right? All of that changes and should close those defects on their own. Most of your ASDs and VSDs are closed by the time they reach like 6 months to 2 years. If they're not closed by then, and they are causing issues, they will go in and surgically fix them. If they are not causing any issue and they still have them, they will just watch and be followed by a cardiologist, but not necessarily go in and do anything. Why would we, if they're not causing anything, why would we just wait and watch versus going and closing them?
Risk versus.
Yeah, it's not hurting them.
Risk versus benefit, right? Like if that defect isn't causing any issues, like if they're able to run around and play normally and not have any issue, we're just gonna leave it, right?
My daughter actually has both, that is, and PSD, which is fine, they're just watching.
Yeah.
It's like follow up every year, every 2 years, they want to come see her.
Yeah, unless something happens, right? Unless you start showing some symptoms, because you're going in and you're going in. It's an open heart surgery. You're risking infection. You're going into the heart. You have to like put them on rest, right? Or VSD, we want like 6 weeks of rest because it's such a
Is it
thick
open
muscle.
heart?
Some of it is, yeah. It depends on how they go and do it. Cool. So cardiovascular changes in childhood. So our younger kiddos are going to have a much higher rate, right? And as they grow, everything decreases. Except for their blood pressure actually goes up, right? Heart rate, respiratory rate go down, blood pressure goes up. Okay. We're looking at in infancy, your heart rate is somewhere between 90 and 160. Obviously gradually decreasing. Our younger kiddos, blood pressure is 80 over 55, right? That seems really low because when we talk about a blood pressure of like 80 over 55, you think of like this like, older patient who's like about ready to pass out on you and go, have a nice syncopal episode. But that is normal for them, right? Okay, so don't freak out when you have a low blood pressure. Like it's normal for them. okay? By adolescence is about where it kind of levels out and their levels are similar to that of an adult, okay? So we're gonna look at some risk factors that affect our heart abnormalities. So we're gonna look at ones that affect congenital and acquired. So congenital malformations, genetic syndromes, what's one that you can think of that has a lot of heart defects? Down syndrome. Yeah, Down syndrome was one that has a lot of genetic or congenital abnormalities. VSD is a very common one for them. History of familial congenital disorders. So our case study that we'll take a look at, there's a male line associated genetic issue. Okay. Maternal drug or alcohol exposure, toxins, a number of things that kind of fall into that category. Was something exposed during utero that then caused that development at that time to have an issue? And also prematurity, right? So we just talked about fetal circulation, but if they're born early, should those things close at that time? No, because their body thinks it still needs it because it's not fully developed, right? Okay. Looking at factors that affect acquired issues, so infections are kind of the biggest one. The ones that we're going to take a look at are Kawasaki's and rheumatic fever. Okay. Endocarditis is another one. Endocarditis is what? Infection of the heart itself, right? Obesity, diabetes, drug, alcohol, hypertension, chemotherapy. There are certain ones that we give that have a direct correlation to heart issues, so we make sure that they have an EKG before we start treatment and frequent ones as we move through to make sure that there's no cardiac changes as we're administering that chemo.
So with differentiating congenital versus acquired, because they both have maternal drug or alcohol exposure, both.
So this for congenital is during utero. This that was really weird. This drug and alcohol is if the child themselves was doing something. Right, like if they were ingesting drugs or like alcohol and stuff like that, that would be that acquired, and that they were doing something that caused them to have an issue. Okay. Connective tissue disorders, autoimmune, hyperlipidemia or high cholesterol, organ transplants, right? If it's not their own and they're having to take like anti-rejection meds, those are all things that can cause them to have acquired issues later. Okay. So how do we know we have a cardiac disorder? What's the first thing you're going to see? Yeah, changes in their vital signs or their appearance, right? They're going to look blue, especially if they have a disorder like tetralogy of Fallot, right? But cyanosis is a huge one. However, is it normal for them to have some level of cyanosis right after birth?
Yes.
Yes, right? How quickly should that go away though? A couple days, right? Yeah, their hands and their feet, like within the first couple days. However, if it sticks around and you're taking their vitals and they've got low sats, we might be looking at the fact that they have a cardiac disorder, right? If they've had prenatal care, a lot of times it can show up on like the ultrasounds and stuff like that, but not always, okay? Other things that we're looking at, irregular heart rates, edema, right? Especially associated with which one?
Right.
Congestive heart failure, right? So this is one that's really, it's more of an acquired one as a kind of side effect of a congenital one, right? Okay. It's a congenital one is causing an acquired one. So then we'll see edema, clubbing of the fingertips. This is more long-term, right? So anyone, any baby right at birth, should they have clubbing? No, right? Because they were getting all of their perfusion through the placental fetal circulation, right? They're not having to work through all of their structural defects to make sure that they're perfused right. So this is more of a late sign, right? So again, like, you know, like our kiddos with like cystic fibrosis and stuff like that, where they have long-term issues.
Would that change though if the mom had like hypertension throughout the pregnancy and the baby wasn't getting perfused correctly?
No.
No.
You still
They
won't see.
barely even have fingernails when they're born.
Yeah, yeah. It's not something that you'll see at birth. It's a long-term effect of, or long-term result of extended cord perfusion. Fever, but not always, and then retractions. Okay, so we talked about retractions as related to like a respiratory issue, but if it's a cardiac defect causing respiratory issues, right? Like if it's getting backed up, it's not perfusing through the lungs like it should be, and we're getting like pulmonary hypertension, are they going to have an increased work of breathing, trying to move things through? Yes, absolutely. Okay. So how are we going to test for it? We've got some non-invasive ones, right? So we've got our pulse ox. What's that going to tell us? And how are we going to test them? Okay, it's going to tell us their oxygen saturation. Are we just going to do it on one extremity? You're going to do it on all four, right? So this is our CCHD test. We want to know, do they have a congenital heart defect? So before they go home, we are going to check their oxygen saturation on all four extremities and make sure that it's within a couple of points of each other, okay? We're going to look at their ECG, right? Because what's that going to tell us? Yeah, right. It's going to tell us all about their electrical conduction in their heart, right? This is a problem for ASD and VSD. Why?
Because the pathway is being disrupted by
Absolutely, right? The ASD and the VSD are defects right where the electrical pathway of the heart goes, right? Right down those septums. And so if you have a big hole where that is going, is it going to disrupt your electrical pathway? Yes, right? The bigger the hole, the bigger the issue, right? The echo, right? This is an ultrasound of the heart. What's this going to tell us?
Shows us those blood flows.
This is where we're going to see the actual blood flow of the heart, right? Where is it going, and is it mixing where it shouldn't be, right? And then your chest x-ray, right? Why are we going to do an x-ray of the heart? What is that going to tell us? Yeah, right? You can see the outline of the heart. What does it look like? In tetralogy of Fallot, the heart actually shifts a little bit, right? So it's not positioned in the chest like it should. It becomes more of like a boot shape in the chest. So we can see, is there like cardiomegaly? Has the heart increased in size as a as an effect of these defects, right? Our invasive ones are cardiac cath, right? This is actually we're going to go inside. This is where they go up the vessels and into the heart. So this is where we're going to see inside and visualize the heart inside, right? They're going to be able to see those. And then we've got some labs, right? Our BNP or NT or pro-BNP. These are our heart failure biomarkers, right? So we're looking at, is there like a breakdown of the heart? What are these markers telling us?
For the catheterization, I get it with like, if you're looking for a blockage, like older patients, but infants aren't necessarily, or kids aren't necessarily gonna have blockages. What
Not necessarily
else
like-
would they use
They could look at the valves, like how are the valves working and stuff like that. So, yeah, or are there like any like lesions inside there? They're looking for a number of things. But those vessels, the inside of the chambers and the valves are really what they're looking at and seeing how those are working. Okay, our troponin, that's our myocardial injury marker, and then our electrolytes, so sodium, potassium, calcium. All of those are going to tell us how is our patient doing. Right? So we've got some medical treatments that we can do. Our first line is medication, right? See if we can treat the symptoms without being too invasive first, okay? If that's not working and they're having continual problems, our next step is to do what? That cardiac cath, right? Through that cardiac cath, they can repair some of those defects, okay? And then if they're more extensive, so like tetralogy of Fallot, where they're really having to go in, because they'll take vessels from different places to kind of rework everything, it's going to be a little bit more than just your cardiac cath. This is where they're going to go in and they will open up the heart and kind of do all that stuff there. Okay. What are some medications that we're going to see within this these cardiac disorders? Okay. Beta blockers, ACE inhibitors, Lasix. Lasix for what? For congestive heart failure, right? We want to get rid of that edema, okay? Right? Digoxin, we're looking at improving the contractility of the heart. So do we just need to like control the contractility? Do we need to make it stronger? Do we need to, slow down the contraction of the heart? What's going on with that, right? Do we need to lower blood pressure? Are these issues causing that? Right? So we're gonna, it depends on what the kid is exhibiting and what we're trying to actually treat within that disorder, right? What you're gonna see. Right, so a little bit more on that, right? So our diuretics reduce that fluid overload, the symptoms of congestive heart failure, so that the heart isn't working so much. So you might see furosemide or spironolactone, those inotropes, those are gonna improve that contractility. The biggest one we're gonna talk about is digoxin. Your ACE inhibitors, those are gonna be your enalapril and captopril. The only one that you're going to need to know is digoxin. Okay. And then you got your beta blockers like propranolol. Okay. Our medical treatments. I think you have something similar to this in your book. I don't think I actually pulled it straight from your book. But we're looking at oxygen, right? So our oxygen is going to do what? Yeah, it just provides that supplemental oxygen, right? However, not all of your kids are actually going to be on it, even though they have a very low percentage, right? So for some of the defects, we know that their percentage is going to be low, like down into like the low 80s, and that's okay. That's where we need them to be. It reduces stress. I know it sounds weird, but it reduces stress on the heart and everything like that, so that they're able to manage their disease process a little bit better. Okay. We've got chest physiotherapy, postural drainage, so if we have to move them in certain directions, right? Changing their body, help with that extra fluid. They might need a chest tube. You might see, especially after an open heart surgery, that they have a pneumothorax. So this is where you would see maybe a chest tube come in, right? So as they're in there working around, they cause the patient to have a pneumothorax, so they might need that. And they might have a pacer. Why might they have a pacer? Yeah, so like especially with your ASE and VSE, if you're disrupting that electrical pathway, if you fix that hole and close it, have you fixed the electrical pathway? No, and actually you could have made it worse. So, again, we want the EKG before, and we're gonna do an EKG after to see if what we did disrupted that electrical pathway anymore, right? But if it's disrupted, are they gonna need a pacers that kind of help with that electrical pathway? Absolutely. Okay. Our surgical procedures for those congenital defects, corrective ones aim to restore the normal anatomy, right? So for an ASD, VSD, we're just gonna go ahead and close the hole, right? Seems like a simple procedure. They just patch it, close it, okay? Palliative procedures just are procedures done to improve circulation. So in tetralogy of Fallot, you've got a whole bunch of stuff going on, right? You've got your VSD, you've got ventricular hyperplasia, all sorts of things going on. So the circulation is restored palliatively by taking arteries and veins from other locations and like attaching the pulmonary artery to the veins and stuff like that, right? So that there's a little bit of restored pathway so that they're getting a little bit more oxygenation before we go in and do the full procedure. Okay. An example of that is the Blaylock and Tussock shunt or PA banding. You don't need to remember those. I'm not going to test you on what those are. Okay. And then you got hybrid procedures where they do some things surgically and some things through a catheter, and that's that Norwood procedure. So these kids go through a lot, right? Our care of them, though, first and foremost, starts with improved oxygenation, right? What interventions do we need to do to improve their oxygenation? Okay. Looking at adequate nutrition after that. If they're not growing and developing and bringing in the proper nutrition, are they going to do well? Yeah. But we know that with some of these disorders, they can tire out a little bit more, right? If they're using what oxygen stores they have available, they will tire out during their feeding. So what's one thing that we can do to increase their nutrition without wearing them out? We could do an NG tube. However, if we put down an NG tube, it could lead to oral aversion, meaning that when we start and reintroduce oral feeds, they don't want it, right? Because they haven't had anything in their mouth. And so we really kind of want to avoid that if we can. So we still want to encourage them to take oral feedings so that it doesn't happen. But instead of giving them a larger volume, we can actually decrease the volume of the feed by increase the calories at the same time. So one of the ways that we'll do that, you know the ready-to-feed formula bottles that are already like pre-mixed, right? You just pour them in the bottle and they're ready to go. To increase the amount of calories in that same amount, we will take powdered formula of the same thing and add that to that ready-to-feed, right? So like a half a teaspoon of that powdered formula increases it from 22 to 24 cal. So it bumps them up, 2 cals in that feed alone, right? But the same volume that they're getting. Okay. So we'll decrease the volume, increase the calories. Okay. We're gonna focus on helping the family cope, right? Assisting the child and family with that piece of it. If they've gone through and they've had a massive open heart surgery, what are they gonna look like when they come back? Kind of scary. Think they're gonna have tubes and drains everywhere? Yeah, you think that's gonna be frightening for the family?
Yep.
Yeah, so how can we prepare them for that? Telling them in advance, educating them in advance, right? This is what your child is gonna look like, right? They're gonna come back, they could have chest tubes, they could have drains, they're gonna have incisions, they're gonna have bandages everywhere, right? And then talk them through what you're gonna do, how you're gonna manage all of those things, right? You think that's gonna help with their anxiety a little bit when their child comes back? A little bit, because they're expecting that. They know that their child's gonna have that. Are they still probably going to have a big emotional response when they do see their child for the first time? Probably, right? But it's not gonna be as bad as if they weren't aware of what their child was gonna look like when they came back, right? So help them cope through that. That moves into the next one, post-operative care, right? Providing all of that nursing care post-operatively. So we just talked about what they're gonna have. So what does your care look like in dealing with them post-operatively? What are they gonna need? Pain management. Infection prevention, right? So whether that be antibiotics, wound cleaning, dressing changes, right? All of that. We want to keep them nice and clean and keep them free from infection. Because their surgery just was done on their heart, right? We open up their chest and expose their heart. If they have an infection there, where's it gonna go? Everywhere, right? It's gonna pump out everywhere, okay? So our next one there, preventing infection, right? So making sure that the family is educated on what? Hand washing. Hand washing is gonna be huge. Making sure they're washing their hands every single time before they touch their child, right? We are gonna make sure that we're doing hand washing. We're gonna do whatever our dressing changes say that we have to do, right? Providing all of that education, okay? From start to end. So we're gonna start educating them post-surgery and then educating them post-surgery, right? So what does their recovery time look like? You know, if they're, how long do they have to not be overly active before they can do strenuous activity, right? What is their outlook look like for them as they progress and develop through childhood? Can they still do all of the things a normal child would after they've had their heart surgery? And when can they do those things, right? Cool. Okay. So what's your assessment look like? Okay. So we want to make sure that we're getting their temperature and weight. Why? Absolutely, right? This is gonna help with our accurate eyes and nose. But we wanna know, do they have a temperature right now? Because if they have a temperature right now, what do they likely have? They could have some sort of infectious process. Are we gonna cut open their chest if they've got an infectious process? Absolutely not, right? That would be awful. Okay, we're gonna evaluate their extremities. What are we gonna look for? Okay, edema, their perfusion, their pulses. Do they have clubbing, right? So what if this is a kid who is coming from an area where they didn't have adequate treatment early on, right? And now we're dealing with an older kid who has, you know, tetralogy of Fallot as a school-age child, right? Do you think they're gonna have some clubbing of their fingers? Probably, right? We want to auscultate the heart. What are we listening for? Murmurs, clicks, gallops. What's it sound like, right? Does it sound like it's got a normal rhythm, or does it, like, you know, beat and then take a pause and then start beating again? What's it sound like? We want to know, is it regular? Are there abnormal sounds, right? And then looking at their respiratory status, right? What are we looking for there? Rate, rhythm, effort, right? Are they perfusing? Okay, all of that kind of goes hand in hand. Okay, listening to their breath sounds. What are we listening for? The breath sounds. Listening for crackles, right? If they've got crackles, what might they have? They might have like pulmonary hypertension, right? Things are backing up because of the way the blood flow is moving and perfusing to the lungs. Good. We want to know, what's the history of the presenting illness, right? So when did everything start? Okay, did it start at birth? Did it start, a couple months after that? How did they progress, right? Were they fine for a while and then they started showing symptoms, or did they have symptoms the whole time? What were you doing at home? What medications have you already been prescribed? What's working? What's not working? Right? What's bringing you to this point right now where now we need to do something, right? What's their activity level at home? Are they able to do things normally, or do they get winded just walking from like their bedroom to the kitchen, right? Do they get worn out? Okay. Are they using all of their oxygen reserves just doing that little walk? Okay. Do they have a history of orthopnea? Meaning what? Difficulty breathing laying down, right? Like what position is difficult for them to be in? Do they get easily fatigued? Do they start breathing harder while they're trying to eat? Or just, a simple little walk, is that causing them to get fatigued? Are we seeing that they've got growth delays or failure to thrive? They kind of go hand in hand. You're gonna kind of see both in there. So your growth delays, like for older kids who might have tetralogy of Fallot, they might be smaller in stature. They're not gonna eat as well, they're not gonna take in, they're gonna grow. Our failure to thrive, you're really gonna see that more so in our younger babes who they're not able to take in either like breast milk or formula because they're choosing to, again, breathe over eat, right? So their defects, if they're mixing with more deoxygenated blood that's getting sent out, it's not going to take much for them to use the good oxygen they do have, and so then they're going to choose to breathe over eat, and so then you're going to see that like failure to thrive. So they're not growing, they're not like putting on weight, and so when they're coming in for like their well checks, you're going to see that they're either decreasing in weight or they're not growing in any way. Squatting. Do they have a history of squatting? Which one does this one go with? And why would they squat? Tetralogy of Fallot, absolutely. So what does putting them in the squatting position do? It helps with oxygenation in which way?
It's easier for them to breathe.
It does make it easier for them to breathe. So in the squatting position, you're essentially sending like blood flow that's like normally in the lungs back to the core, right? So you're really just kind of, when they're in that position, you're just mostly perfusing your core. And then like if you're in that position for a while, when you stand up, you kind of get like lightheaded, right? So that is like everything from here going back into your extremities, right? So you're essentially just sending that blood back to the core, so it's a little bit easier for them. And we'll talk about TET spells and that when we get to tetralogy of Fallot. Okay. All right, we want to know: do they have birth problems? Do they have congenital malformation? What was their birth history? Do they have a history of a NICU stay? Do they have frequent infections? Are there any chromosomal abnormalities? We've already mentioned one before. Down syndrome, right? Do they have a history of prematurity? Do they have any sort of autoimmune disorder? And do they use any medications like corticosteroids or anything like that? Okay. Our psychosocial interventions, right? Our biggest one is to make sure that we explain everything. Why is explaining everything really important? Really to prepare them, right? This is a huge deal, especially if they're going in for an open heart surgery, right? We want to make sure that they are being provided all of the information that they need at a level they can understand, right? So again, what's the average reading level? like 5th to 8th grade, depending on where you're at, right? So making sure that you're giving them all sorts of diagrams and pictures, right? Because are they gonna be knowledgeable in the anatomy of the heart and what you're talking about? No, right? So give them pictures and diagrams of what normal circulation looks like, ones with the defects that their child has. Explain to them, you know, this is the way the blood should go, this is the way the blood is going, and this is why we need to fix it, right? Because this is what we're seeing. Your child has poor perfusion, they get fatigued easily, they're not eating well, they've got all of these other issues. So we need to go in, we need to fix these so that your child can thrive, okay? Encourage expression. Allow the parents and child to voice their feelings, concerns, and questions. Why is that important? Okay, so you're getting an understanding of, yeah, so you're getting an understanding of how much did they take in from what you gave them. You're meeting them where they're at, right? You're making them feel heard if you're actively listening to what they're telling you, and you're giving them that time to be able to do that, right? So that it doesn't seem like you're rushing into the next patient's room, right? I was just at the Men in Nursing conference this last week in Orlando, and one of the students that I was talking to was a new grad who was having issues with their preceptor because he said that the preceptor was telling him he was spending too much time with his patients. He was still getting all of his tasks done, he was charting on time, all of his meds were on time, but his preceptor told him he was spending too much time with his patients. He wanted to establish a relationship with his patients, to develop that rapport, to develop that trust, right? All of those things that we talked about that first week, right? So his biggest thing with his preceptor, who he was like, it's like night and day. This was the second preceptor he had. His first preceptor had all nice things to say, right? Everything that he was doing was right on track, but this one just seems to really have a problem with making a connection with patients. And he's like, I don't understand. He's like, I'm doing everything I should, I'm getting everything done, but I want to talk to my patients. I want to get to know them. Is that why would you have that view that like spending too much time with your patients is a bad thing? Right. As long as you're getting things done, does it matter how much time you spend with your patients? No. Right? It's okay. Right? So he's allowing that piece, right? That encouraging expressions, listening to them, actively giving them time to ask questions, talk about what's going on, right? Even if it's not necessarily about what's happening right now, just having general conversation with them, is that going to put them at ease? Yeah, absolutely, right? And that goes along with providing time, right? Provide ample time to address any questions they have, right? Those two things go together so that they're, again, developing that rapport, developing that trust with you, right? Are they going to tell you more about what's going on if you're starting to develop that relationship with them? Yeah, some of our patients don't want to talk about it because they just think we don't have the time, right? But make time, it's okay. Encourage participation, right? Encourage the parents and the child is developmentally appropriate to provide that care that they need, right? So can we, if we're starting to like change dressings and they might need those when they go home, are we gonna encourage the parents to start doing those things so they know how to do it at home? Absolutely, right? Sometimes we send kids home with like JP drains. Are the parents gonna need to know how to do those at home? How do we know that they know how to do it at home? Because we've educated, we've watched them do it. They've watched us do it first, right? We showed them how to do it, so they are prepared to go home, right? Help them participate in their child's care so that the better outcome is what we see when they do go home, right? If we provide all of that stuff ahead of time, again, we're less likely to see them readmitted for some small thing that they could problem solve at home, right? By going through those what-if scenarios with them before they get there, right? Before discharge. So we kind of already talked about this, right? The parent teaching for surgery, so talking about their anatomy, give them diagrams, right? Because they're probably not aware of what the heart actually is, what those structures are, what they do, how blood circulates through there, right? Talk about their incision. Where are they gonna have their incision? What is it gonna look like, right? The actual surgical procedure. Do they need informed consent for this? Yes. What things warrant informed consent? Okay, so you said anything invasive. Yes or no? No. Do we need informed consent for an IV? That's invasive. Do we need informed consent for an NG tube? That's invasive.
Would it be like a permanently invasive procedure?
Kind of. So things like surgeries, MRIs with contrast, right? So anything that is outside of the standard consent to treat when patients first get admitted, right? They're going through all that admission stuff and they sign a consent to treat. That allows us to cover things like an IV or an NG or simple nursing things like that. If they're gonna go in and they need a surgical procedure, which could result in death, right? They need informed consent. If they go in for an MRI with contrast and there is a risk for an adverse outcome, they need a informed consent, right? There is something, a procedure that goes above and beyond normal consent to treat, where the surgeon needs to come in or whoever is doing the procedure needs to come in and talk about, this is what we're doing, this is the increased risk for this procedure, this is what could happen, right? This is what we expect to happen, but this could happen. So the parents have to sign, yes, I know that there's an increased risk to my child for doing this procedure, I'm okay with them doing it, right? And then they sign it.
You still need it for like vaccines.
You do need it for vaccines, right? Because there could be an adverse thing to some of those vaccines, right? My child had that. He had the most awful rash for like 9 months after being an MMR. Okay. Who does this? Who comes in and talks about the surgical procedure and gets that informed consent? The surgeon. Can we do that? No. If the surgeon walks out and your patient says, what did they say about that one thing that they're gonna do? Can you add that information? Nope. You have to call the surgeon back because the patient has to have all questions answered before they can sign that informed consent. If they have any questions related to that procedure before they sign it, you cannot let them sign it. They need to be clarified before the procedure. Okay? You're gonna talk about their activity level. What restrictions do they have post-surgery? Where are they gonna be after surgery, right? So maybe they were just being housed on like the med-surg floor prior to surgery, but where are they gonna go afterwards? Probably to the cardiac CVIC, right? They're gonna go there. They're gonna be in recovery first. Can the parents see them in recovery before they go to the CVICU? Yeah, depending, right, on hospital restrictions and stuff like that, but they should be able to see them there and then go with them to wherever they're gonna be after. Are there any nutritional restrictions afterwards, right? Usually we don't restrict anything, but they might be NPO for a while to make sure that the surgeries that they did actually stick, right? So we wanna make sure that, like, you know, if they do a shunt, that the shunt doesn't like rupture and then they have to go back in. Because if we fed them and that happens, can they go to the OR right away? Well, they could, but it might not come out well, right, if they have a full stomach, right? So how long are they gonna be on restrictions for? What are they gonna look like after surgery and what medications are they gonna be on? Okay. So what are some diagnoses for a child with a congenital heart disease, right? One of them being decreased cardiac output. Why are we gonna see decreased cardiac output? Let's go with before they had surgery with these. Why would they have decreased cardiac output?
Holes that blood is moving into instead of moving where it should.
Absolutely, right? Some of those defects send blood back to the heart or back to the lungs instead of sending out to the rest of the body, right? So there's decreased cardiac output going out to the rest of the body because it's going to the lungs instead of where it should go, right? Ineffective tissue perfusion related to that decreased cardiac output, right? Or they have an altered blood flow. What if they've got coarctation of the aorta? Is that going to restrict their blood flow? Yeah. It's going to increase it in the upper part of their body, but it's going to decrease it in their lower part, right? Excess fluid volume, right? We're going to see this more so with our congestive heart failure, right? If they've got fluid backing up, we're going to see that they've got that excess fluid volume. Impaired gas exchange, more so with our pulmonary congestion, right? Or our pulmonary hypertension. So if they're sending more blood back to the lungs, is it going to get backed up? Yes, absolutely, right? And because we've got all of that fluid there, is it going to oxygenate well? Yeah. All right, so let's look at some hemodynamic characteristics of those congenital heart defects. So we're going to look at decreased pulmonary blood flow. So these are going to be our cyanotic. So this shunts right to left. Okay. So we're going to look at tetralogy of Fallot. Okay. Tricuspid atresia is also another one, but the only one that we're going to cover is tetralogy of Fallot. Okay. Your increased pulmonary blood flow are these that are acyanotic because they are sending more blood to the lungs to get perfused. So these are going to be your PDA, your ASD, and VSD. Okay. They do cause excess blood flow to the lungs, which can lead to heart failure. Okay. And then our obstructive one we're going to take a look at is coarctation of the aorta. However, aortic stenosis and pulmonary stenosis also fall into those categories. Okay. So, tetralogy of Fallot, ASD, VSD, PDA, and coarctation of the aorta. You have 5. Okay. Right? And then we're going to look at 2 acquired. We're going to look at Kawasaki's and rheumatic fever. So you have 7 altogether. Is that manageable? Yes, that's very manageable. Very manageable, right? Yes, so it's going to be your tetralogy of Fallot, these here, your PDA, ASD, and VSD, and then your coarctation of the aorta. These are your congenital ones, and then the 2 acquired we're going to take a look at are going to be Kawasaki's and rheumatic fever. Okay. All right. So this one just kind of gives you an idea of like blood flow through the heart, right? So you've got your normal heart, and it shows all of the blood circulation here, right? Your ASD, you've got a defect in the atrial septal wall, so your blood flow is going to go from left to right, okay? Because it's stronger in the left than it is in the right, okay? Your VSD is also a left to right shunting. Your left ventricle is going to shunt it back to the right, so then it's going to go back to the lungs, right? Your ASD is the same thing, right? It's going to go from the left to the right, and then it's going to go back to the lungs. Okay? Your coarctation of the aorta happens outside of the heart, right? So your ASD and VSD and tetralogy of Fallot, everything is inside. Your coarctation is outside though. This is in the aorta after your vessels that feed the upper part of your body. Okay. So with tetralogy Fallot, and we'll get there a little bit, but the ones that you're going to see, you're going to have a narrowing of the pulmonary valve, thickening of the right ventricular wall. You've got a VSD. Your aortic valve is enlarged as well. Before we start actually getting into the defects a little bit more, do you want a break?